everyone. My name is Kina. Thank you to everyone that is here today for our August 2025 Grand Round. As a friendly reminder, we will be recording this presentation and also be posting and producing an AI summary. Feel free to turn on closed captions on the bar below that may accompany you throughout the presentation. We have today our Global Offsite Care Medical Director, Dr. Pecchia, who will be introducing our speaker, Dr. Babu.
Thank you, Kina, and welcome everyone. We're excited this morning to have a new addition to our speakers bureau and guest speakers list here at Global Offsite Care and our global grand rounds, which are held monthly as a component of what we do at Global Offsite Care, which is a non-governmental organization to facilitate building telemedicine bridges and services to underserved areas around the globe. So I'm Dr. Pecchia, Gregory Pecchia, affiliated with Western University of Health Sciences in California and serve as volunteer medical director of Global Offsite Care. This morning we have Dr. Sathish Babu, who's one of the leading endocrinologists in Bengaluru, India. He has done his medical degree from Government Medical College, Bellary, which is now the Vijay Anagar Institute of Medical Sciences, and his MD in General Medicine from Bangalore Medical College, Bengaluru. Following this, he worked in world-renowned hospitals like Cambridge University, Cambridge, King's College Hospital in London, and Guy's and St. Thomas Hospital, also in London. His endocrine 5 years of fellowship was from these reputed institutions. He was a consultant endocrinologist at Cardiff University and Cardiff, UK, before moving back to Bangalore. He is currently associated with the Sri Sathya Sai Sarla Memorial Hospital in Bangalore. Welcome, Dr. Babu.
Thank you. That was very kind and generous. Yes, my specialty is endocrine, so I thought I will pick up very simple thyroid blood test, which I've come across in my practice, how it educated me, how it made my understanding of medical endocrine issues in a better way. And what I learned, I'll be sharing today to make it more relevant for the current happening in the world. I thought simple thyroid blood test and health tariffs, where the tariffs is coming from. So that's a bit political, but you will understand why as I move to the presentation, you will understand why the tariff is also title which is appropriate. A simple thyroid blood test, how it prevents health issues, health complications, health tariffs is what I meant when I chose the title. So let's jump into the first case. First patient whom I came across almost, if I put it across, I think 18 years back. This is a Nigerian gentleman, 60-year-old, came with a bit of abdominal symptoms of feeling fullness in tummy and generalized weakness and aches. He has diabetes. He was on oral hypoglycemic agents, gliclazide and metformin, along with insulin novorapid and Levima. He was admitted under surgical gastrectomy for his abdominal symptoms, but endocrine referral was given so that glycemic control can be optimized. This is, again, I have taken the exact case sheet seen by Dr. A, Dr. B as a team. They were asked that the management plan was quite elaborate, extensive. You can see all the tests they have asked for. What is striking is there is thyroid profile as well in the last. And of course, there was fasting blood sugar, postprandial blood sugar, HbA1c, lipid profile also requested, along with my consultation, Dr. Sathish Babu, for diabetes control. So they had asked for diabetes specific glycemic control as a reference. On examination, there was no endocrine phenotype. There was no features suggestive of any endocrine clinical features. His HbA1c was 8%, which is not bad for a 60-year-old gentleman who has diabetes for such a long duration. Of course, he was on basal bolus insulin regime. I changed insulin Levemir to Insulitant, being very expensive for at that point of time. Of course, thyroid blood test was requested by surgeon, which was another endocrine blood test. So these are his reports, blood reports. You can see T3, T4, TSH, and HbA1c of 8%. Calcium was normal. So T3, T4, TSH. If you interpret low T3, low T4 with normal TSH. TSH was probably inappropriately normal if you consider low T3, low T4. So that's a clue. That's a abnormal test. So what is the differential diagnosis? It can be primary hypothyroid when people are on thyroxine replacement but not taking regularly. Poor compliance. It can be sick thyroid. If somebody is systemically unwell, you can get T3, T4 subnormal with TSH being normal. But more importantly, it can be central, that is pituitary hypothalamic hypothyroidism, which is secondary hypothyroidism. So as soon as that TFT was looked into, immediate urgent cortisol level was sent. It was way below normal range. So it was 1.9 and the lab reference in our part is between 5 to 25 micrograms deciliter. So he had central hypothyroidism and hypocortisolism, pituitary hypocortisolism. So MRI pituitary was requested. Working provisional diagnosis was hypopituitarism. So quickly, can it be sick thyroid? You get this picture, but sick thyroid is usually transient. You have low T3, low T4, we had the TSH being normal, within normal range, but all this recover once the systemic illness gets better. So is MRI clearly showed, if you see the big gland, I'm sure you can see my pointer pointing out, and this is the optic chiasm. Optic chiasm is pushed laterally to the right side. So the optic chiasm is getting abated. It's a huge pituitary adenoma, macroadenoma, what we call. So again, with contrast, you can see both the coronal and sagittal view, big tumor, and axial view, you can see again quite big tumor. So pituitary macroadenoma, abutting optic chiasm with hypopituitarism and type 2 diabetes was the final working diagnosis. Obviously, he was immediately started on IV hydrocortisone 100 milligram stat. Then he was given a day of hydrocortisone injection, and the second day, third day, we changed him to oral hydrocortisone to begin with 20-10-5 and taper down to 10-5-5. Thyroxine replacement 100 micrograms was started once a day, and he was referred for neurosurgical removal of this macroadenoma, which they planned, but he had financial issues, so he took discharge on request. So you can imagine person coming with some constitutional non-thyroid, non-pituitary symptoms, but simple thyroid blood test T3, T4, TSH gave us the clue for a big problem which was probably there for more than 1 year, 2 years, looking at the size of his tumor. So normal TSH, low T3, low T4 and low T3 were the clue for this case. So let's move on. We will have 3, 4 cases like this, and you will understand what I'm trying to portray or I'm trying to narrate as a medical message or a clinical understanding of simple thyroid blood test and how to build the case and come to conclusion to prevent bigger issues happening. So this is again a 15-year-old girl. She was sent to us with a diagnosis of pituitary macroadenoma. She already had MRI of pituitary gland, of brain, and the brain MRI picked up pituitary macroadenomas. This was the diagnosis. So she was referred to our hospital for surgical intervention, transpenoidal surgery for macroadenoma. Of course, as a pre-operative requirement, she was referred to endocrine to me for pre-operative evaluation. So let's go into the history. She has gained weight in last 1 year. She has headache almost regularly, bifrontal more during morning, and blurring of vision, which she claims to be there for last 1 year. She feels tired, skin is dry, menstrual cycles are irregular with menorrhagia, with increased flow. So no history of polyuria, polydipsia. There is no discharge from her breast, no galacturia, no double vision. Family history, mother has primary hypothyroidism on thyroxine replacement of 150 micrograms. This was the history. Clinical examination, nothing obvious other than hirsutism and coarse skin. Skin was bit coarse for her age of 15 years. Rest all looked normal. There was no endocrine features or Cushing's. There were no classical thyroid or hyperthyroid features on examination. Our visual fields were full. Our extraocular movements were of the eye was full range. Fundi was normal. Visual acuity was normal. Visual fields on finger confrontation. There was no hemianopia. Obviously, there was no sensory or motor deficits. We got a visual field documented pathway compression field testing. Because she came with macroadenoma, visual fields also was checked. Skull X-ray was done. Mild erosion of cellular floor was done. Report. This is the MRI. You can see again both. This is coronal view and sagittal view. You can optic chiasm. There is a bit of a space between optic chiasm and the pituitary tumor or pituitary enlargement. You can see a sort of a central lesion which is quite big, and more views. And this is again, you can see coronal and sagittal with contrast. So impression of MRI was features are suggestive of pituitary macroadenoma with supracellular extension as described. And you can see it is seen closely abutting to optic chiasm, chiasmatic recess. Pituitary infundibulum is not seen separate from the lesion. So it all boiled down to pituitary macroadenoma as a radiological diagnosis. So what next? Of course, we have not gone into the hormonal assay. So obviously, hormonal, she has come with pituitary macroadenoma with an MRI without any blood tests. Blood tests were sent. Cortisol was within normal range, growth hormone normal range, FSH normal but LH low, prolactin bit above the normal range, very tiny bit above the normal range, TSH more than 75, T4 very low, T3 very low. So it clearly indicated she has primary hypothyroidism. She diagnosis of primary hypothyroidism with pituitary TSH hyperplasia. TSH thyrotrome hyperplasia was the working diagnosis. Surgery was cancelled. Obviously, the surgery was cancelled. She was in the gown when I saw. So fortunately, her surgery was cancelled. T4 replacement, that is thyroxine replacement, was started 100 micrograms once a day. Thyroid peroxidase antibodies came back as positive. And if you remember, she has a mother with hypothyroidism on 150 micrograms of thyroxine replacement. So she has a family history and peroxidase antibodies are positive. So she was discharged with a follow-up of for 4 to 6 weeks with thyroxine replacement, on for which she is symptomatically better. She had lost 4 kilos. TFTs were normal and serum prolactin also had come back to normal. So 12 weeks, 10 to 12 weeks later, we repeated our MRI. You can see before and after. Complete resolution of the swelling of the lesion on the pituitary gland. This is the before T4 was started. This is after thyroxine replacement. You can see, in fact, pituitary is a bit shrunk for our age. The volume is shrunk for our age. So complete resolution of hyperplasia at 12 weeks. Again, coronal, if you can see central, there is almost touching the chiasm and huge pituitary enlargement. Whereas here you have after thyroxine replacement, you have a normal looking pituitary gland. So complete resolution of hyperplasia. So again, simple TFT was the clue and gave us the right direction to manage such complicated young girl coming with diagnosis label as pituitary macroadenoma. What would have been her life if she had gone under the knife and pituitary gland was removed? She's 50, she would have lifelong she would have suffered from hypopituitarism, hypogonadism, infertility, marriage issues. Imagine. So the thyroid blood tests are so critical and so important, and you have to interpret both on the as a thyroid test and as a pituitary test, because TSH is in TFT. TSH is pituitary hormone, T3, T4 is thyroid hormone. So that interlink and interpretation makes all the difference. So anyway, coming back, hyperplasia, pituitary hyperplasia is a non-neoplastic increase in one or more functional distinct type of pituitary cells. So it's usually because of lack of feedback suppression, which happens from adrenal, gonadal, or thyroid hormone. Lack of dopaminergic inhibition of lactotrophs also can lead to hyperplasia. So most common is prolactin secreting hyperplasia. Next is what we saw, thyrotrope hyperplasia. Rest are rare. Pituitary hyperplasia can coexist with adenoma, and very rarely it can lead to neoplastic or momentous changes can happen. So clinical presentation, this present as pituitary adenoma. What happened in our case, they present with the primary hormone which caused this problem also. So in our case, she had hypothyroid features, subtle, coarse skin, thick skin, gaining weight. These were the clues for hypothyroidism. Of course, she had menorrhagia, which is again a feature of primary untreated hypothyroidism. And once it is big enough, hyperplasia is big enough, you can have local pressure effects, which is headache, visual disturbances, extraocular muscle involvement. So these are from the pressure, from the size of the hyperplasia. Of course, MRI will may not differentiate between adenoma and hyperplasia. Dynamic MRI, usually late contrast enhancement, suggests pituitary adenoma. So if you talk about histopathology, of course, normal structure in adenoma is completely obliterated. So reticulin stain, when you do it, there is a breakdown of reticulin fiber network in adenoma, whereas in normal and hyperplasia, it is retained. So that's about histopathology. So prognosis and management depends on the cause. Which hormone is affected, that is the primary issue. Endocrine effect and the extent of the size, extent of the swelling is what causes the issues. Most cases are reversible. Earlier the treatment, better the prognosis. Time required for resolution, as you saw in our case, it was just weeks. It can be as early as days also, but rarely when the treatment is delayed, it can take a longer time to resolve. So we went on to identify 7 such primary hypothyroid patients subsequently who all had pituitary hyperplasia, and we reported all the 7 cases. And all of them, we saw that there is a resolution of hyperplasia from 6 weeks onwards with the initiation of thyroxine replacement. That's about that case, and subsequently our case reports of 7. So we'll move on to third case. Again, this is a lady, 24-year-old, married, presents with complaints of irregular menstrual cycles for 2 years, and she's concerned about her fertility. She attained menarche at 14 years, had regular monthly menstrual cycles up to 2 years. From 2 years, she's having irregular cycles. And obviously, she's trying for pregnancy but not becoming pregnant. No history of galacturia or headache. Ultrasound done in February 2012 showed anteverted uterus, normal size and contour, normal myometrium, endometrial thickness normal 3.1 millimeter. She had bilateral polycystic ovaries. At that point, or subsequently, 6 months later, thyroid blood test was requested, TSH 2.26, T3, T4, again, if you see, lower end of normal, T4 being lower than the normal. FSH again normal, LH was low. Prolactin marginally high. So she had a doctor in her family who thought she has to see an endocrinologist. But it was almost 1 year, 4 months later that they came and saw an endocrinologist. So February 2012, she has seen a doctor. From then onwards, seeing an endocrinologist was almost 1.5 years later. So endocrine doctor again asked for all the hormone profile. It was me. So obviously, so asked for all the endocrine hormone profile and thought about in pituitary MRI if required. Ultrasound in that period was normal. Again, if you see T3 normal, T4 lower end, TSH low. For the low T3, T4, TSH was subnormal. If you see in August 2012, also TSH 2.26, T3, free T3 2.17, 2.1 is the lower limit, and free T4 0.7 and 0.8 is the lower limit for free T4. So there itself, there was a clue for making something like central hypothyroidism as a diagnosis. But here, definitely, it looked like central hypothyroid when the TFT was repeated 1.5 years late. So she went on to have FSH. Again, repeated FSH was normal, but LH was low. Estradiol was low. Prolactin marginally high. Cortisol was way below the normal range, very low. Sodium, potassium, normal. And MRI pituitary showed squashed. If you see the black color is the CSF. So you have a pituitary gland which is filled with CSF, only thin rim of pituitary tissue, very thin rim of pituitary. So you call this as partial empty cella. Pituitary gland for her age, 22 years, being reproductively active, should have been whole of cella, almost occupying whole of cella, but here it is a squash to the floor of cella. So very small, thin rim of pituitary tissue. So it goes with in the favor of hypopituitarism, partial secondary to partial empty cella syndrome. So she was Obviously, hydrocortisone was very low. Cortisol was very low. Hydrocortisone was started, oral and reduced to 10 and 5. Thyroxine 100 micrograms once a day was started. 8 months later, she conceived, and 9 months later, she delivered a baby girl. So again, somebody with 20 in young age, trying for pregnancy, irregular cycles, investigated with TFT, and almost 1.5 years later, the same TFT gave the clue that it is a more than just hypothyroidism. It was central hypothyroidism with pituitary axis, cortisol axis also being affected. So once you correct the thyroid and cortisol axis, the hypogonadism got corrected, self-corrected, and she went on to become pregnant. So I will just stick to thyroid. So thyroid is a very important hormone, and for both female and male reproductive function. So as you all know, T3, T4 tissues are hormones which work or which have a function all over the body. So if you take hypothalamus, TRH is released, and that pituitary that stimulate TSH release, and TSH acts on T3, T4, and T3, T4 are on thyroid, and T3, T4 are released. TRH itself has a stimulatory effect on prolactin. So when primary hypothyroidism is seen, you have increased TRH and increased TSH. So your prolactin, hyperprolactinemia happens, and prolactin as such suppresses gonadotropic releasing hormone. So simple primary hypothyroidism causes hypogonadism through the pathway of prolactin as well, on top of primary hypothyroid itself affecting the reproductive organs. So that's one way of thyroid affecting the sexual function. Other ways, T3, T4 directly on different tissues, starting from hypothalamus, pituitary, liver, which increases sex hormone binding globulin, on uterus, on ovaries, on testes in male, has direct effect, and that itself will give rise to decreased reproductive function and correction most of the times. Simple correction of thyroid with thyroxine, whether it's central hypothyroidism or primary hypothyroidism, gets your reproductive function most of the times gets reversed if there are no other reproductive issues. So let's move on to one more last patient, a 17-year-old boy referred for short stature. You can see pediatrician referred to me, short stature for evaluation. Height is 135 centimeters. It's way below second percentile. And she had calculated mid-parental height of 168.5 centimeter. For mother, 160 centimeter, father, 164 centimeter. So this was mid-parental height, which he was supposed to achieve. The target height of 160 to 176 centimeter, and he was 135 centimeter, looked infantile, and he had no secondary sexual characters at that point of time. On my examination, on the day of I looking at him, he had Tanner 2, stage 2 sexual development, reproductive development. Height was, as mentioned, 135 centimeter, weight was 30. He was short, and he had already got an ultrasound of his thyroid, absent thyroid gland. TSH obviously was more than 150. T4 was 1.4. T3 4.1. T4 is normally T4 is 5 to 12. T3 is from 80 to 160 is the normal range. And he was obviously underperforming in the school. He was started on 50 micrograms of thyroxine for his weight, and he looked pale, so iron tablet was given. Of course, LH, FSH, and testosterone was also requested because he had Tanner stage 2 with an absent secondary sexual characters for a 17-year-old boy. and he had stunted growth, that is short stature. So absent thyroid gland, ultrasound scan wise of the neck is LH, FSH were low with almost absent testosterone, 0.1 nanograms per ml. So obviously he has central hypogonadism secondary to primary hypothyroidism, absent thyroid gland. So he has a secondary hypogonadism from hypothyroidism. So he went on to be on thyroxine, and almost 2017 he presented first, or 2000, what year was he? July month 2017. And recently, almost 6 months back, I saw him, or 1 year back, I saw him in July month 2024. He was 24-year-old now. His height is 181 centimeter, from 130 to 181. So he has attained mid-parental height, more than mid-parental height, which was calculated as 169 centimeter, but he has attained 181 centimeter. Now he has normal sexual development, obviously, and is on regular thyroxine replacement. This is the journal, if you want to, article, if you want to look into. Thyroid hormones are positively associated with the male reproductive status as well. Thyroid hormones promote masculinization by regulating gonadal sex differentiation genes. Thyroid hormones act during testicular development, controlling Sertoli cell proliferation. Thyroid hormones regulate spermatogonial proliferation via Sertoli cell production of IGF-3. So this gentleman, this young boy, had growth hormone issues and thyroid issues, hypogonadism as well. Both were corrected with the simple thyroxine replacement, and the test which gave the clue was T3, T4, TSH again. So to conclude, in medicine, fine cues suggest final diagnosis many a times when appropriately worked up and interpreted correctly. Clinical, radiological, and endocrine correlation is must prior to any surgical intervention in supracellular or cellular abnormal. Simple thyroid function test, TSH being from pituitary gland, T3, T4 from thyroid, gives a critical clue for much larger diagnosis, preventing or right treatment, reverse the wider consequences and long-term complications from both the primary problem and treatment what you are going to choose. Thank you. This is the hospital medical college where I work, and this is the academic block, and this is the teaching hospital, and one more teaching block is coming. Sri Madhusudan Sai Institute of Medical Sciences and Research, Mudenelli, and Global Rotary is part of their supporting in a big way. Thank you. I'm sure it made whatever the little impact I could make in your understanding of how thyroid blood test, simple thyroid blood test makes a huge difference in managing complicated, simple issues to complicated issues. Thank you.
Thank you, Dr. Babu. That was absolutely fantastic review. Clearly, you have a lot of experience, not only clinically, but also in the academic realm, and really appreciate the perspective and the importance for the clinicians in the room to really hold fast to the importance of taking a detailed history. And also, with the advent of AI and sometimes an overdependence already by some of our clinicians on artificial intelligence generating differential diagnoses, I think this highlights the importance of the clinicians in the room and the medical hunches and intuition that I think many of us hold dear, and to be sure to go to level 2 thinking when it comes to patients like this that sometimes at high volume can disappear into the routine of the medical day. If not nodding the head, many of us, yes,
Yeah,
we
absolutely.
understand that.
You pass the blood tests as simple tests. Yeah, in a
Right.
busy OPD day, on a busy OPD day.
Absolutely. So thank you for that important review. And we have some time for some questions. I'm going to start with a couple. One, tagging on to the title of your presentation, which involved health tariffs. So in that context, from the cases that we saw presented and the details of them that you shared with us, tell us more about the impact, the definition of health tariffs and how that might impact the early diagnosis and detailed workup of our patients who present like this.
Absolutely, yeah. I was conscious when I chose the title because majority of the cases, if you see, have suffered both medically with a delay of, that 17-year-old boy is born without thyroid gland. And mother literally mentioned that she might have seen 50 doctors by then, 50. And simple hypothyroid, simple TFT test was, and this age, maybe 30 years back, it was not easily available. Now, thyroid blood test is done right, left, center. For major means, I would say 50 to 60% of the times there is no indication. Even then, here, if doctor would have spent a bit of his time and put his mind to it, you could have done thyroid blood test much earlier. Even second year, third year, first year itself, it could have been picked up. That is one. So I meant that tariffs is not only about the money, it's about the consequences which are delayed by delaying the diagnosis. And of course, a couple of them, the first two with whom the cases, one is pituitary macroadenoma in a Nigerian gentleman and the other girl. Again, it brings back our clinical judgment and interpretation. And in that young girl with hyperplasia, what a devastating thing which got prevented. She would have been operated just in case if the thyroid blood test was not interpreted correctly or if they had ignored doing tests. This is not a, this is a remote possibility, but even then she was in the operating gown when I saw and stopped this, cancelled the surgery. So very important because these are small issues, but long term and consequences are big.
Yeah, thank you for.
Hope that answers your question.
Yeah, absolutely, and appreciate that perspective. It does occur to me in thinking from my own experience, and then also.
And if you put the if you put money on thyroid blood test, it's 150 to 200 rupees in India. That is probably $3. And what you are going to gain from correct interpretation is huge.
Yeah, and can you repeat that? 50 rupees equals US dollars, approximately how many US?
Currently $2.
Yeah. A clinically relevant question to this, and looking at the population health impact of how we actually screen. I can only speak from the U.S. experience. In the U.S., we're in our medical education, we're taught to screen for asymptomatic hypothyroidism in the U.S. with
subclinical,
with TSH only.
So I would say TSH is a very good screening test for simple. If the story is not complicated, just TSH is good enough. Majority of the times, because you are looking at the more common thyroid issue, which is primary hypothyroidism. If you take the thyroid issue as a complete, you get 98% or 99% of the times primary thyroid as an issue. Only 1 to 2% might be central thyroid issue. So TSH testing for screening in a routine story, in a routine history, should be good enough. As soon as there is a complicated history, like menstrual irregularity, infertility, not fitting into just a simple tiredness, I'm getting a bit of weight gain, my lethargy is increasing. These are simple symptoms. Then you are okay only doing TSH, so you will not miss central hypothyroidism because TSH will come back as normal. Without T3, T4, you you in missing central hypothyroidism will be less likely. As soon as there is more than normal looking history, you have to ask for T3, T4, TSH.
Right.
Then,
Thank you.
then you will not miss central hypothyroidism. You will find TSH is normal inappropriately for low T3, T4. Then it is central hypothyroidism.
Great. Yeah, that's
And once somebody is on thyroxine for primary hypothyroidism, TSH is good enough. Whereas once somebody is on thyroxine for central hypothyroidism, never do TSH because TSH is always low. Do T4. No need for TSH.
thank you. Yes. So important to keep these in
So
mind.
important.
Yeah, both for screening and then the subtle presentations that the people with thyroid and hypothalamic disease and pituitary disorders, as we know from clinical experience, they can develop so slowly and so chronically that especially if access is an issue for routine checkups, if you will, and especially for patients in remote and rural under-resourced settings, it can be, as you mentioned in one of your cases, a lot of time can pass from one assessment to the next. Therein comes my telemedicine question. For our patients, and this applies to the US as well, that are ever increasingly obtaining in many cases, the majority of their health care fully remotely, fully virtually, that we see many people no longer come in for face-to-face evaluations and or to be in a medical center setting where there's testing inexpensive, included in somewhat inexpensive testing like thyroid hormone and TSH screening for patients that are remote who may fall into the category of requiring additional assessment, not only TSH, but TFT testing. Are there inexpensive tests that can be made remote and made available to people in rural areas, underserved areas in your country and elsewhere from your experience to overcome the firewall or the barrier of many people to make their way to our wonderful medical centers where all of the laboratory facilities and the phlebotomy, blood drawing capabilities and the processing happen to be located. So what might be a strategy that you've seen deployed in India and elsewhere to bring that technology to the patient as opposed to the patient to the technology?
No, as of now, for thyroid blood test, as you mentioned, screening TSH for majority of the times is good, but there is no replacement. There is no sort of a strip test or any other modality which can be implemented in the rural areas, and it might not come also because it's become cheaper now. So people who want to invest in finding a solution might say it's not practical and it's not economically viable. Why should I invest? Even though thyroid is also a chronic disease, the management is not as complicated as diabetes and in another chronic disease. And the follow-up can be as long as 6 months to 1 year if somebody is on thyroxine. So the frequency of testing is also less required. So other alternative to blood drawing and lab test for thyroid might not come at all for rural setting. As of now, we should be relying on lab-based tests, and in remote areas, unfortunately, access, affordability is still an issue. So so they get diagnosed very late, and management also gets delayed. Correction also get delayed.
Thank you for that and that perspective. Coming up toward the end of the hour, we have a few more minutes for any other questions or comments. So we have 5 minutes or so available. So from our audience, any comments or questions, you can jump right on to the screen, unmute and pose your question, or in the chat is fine.
Hello, Dr. Pecchia. This is Tela from Nigeria. Can I
Tela?
speak, Dr. Babu? How are you?
Good to see you again.
I have attending the whole session, but I was in a meeting.
This is and
And a
Sablak.
lot of work.
Thank you.
Nice to see you all.
Yeah, Dr.
Very great
Sablok,
project.
thank you. Thank you. Dr. Sablok is very good friend of us, and he has supported our rural telemedicine centers in India, in our part. Thank you, sir. Thank you, sir.
Thank you. Nice to see you.
And thank you, Sablak, Dr. Sablak. Great to see and hear you again. Hope all is well. And Tela, thank you for logging in and attending. And I think,
The meeting is also going on.
yeah, we'll give you back a few minutes of the hour. And again, thank you all for attending, and for those who will be experiencing this really important and impressive presentation today on demand at Global Offsite Care.org. And you can link to that through the Global Grand Rounds page on our website, as well as via YouTube. And for some additional CME opportunities and other cases, feel free to log on to our informal partner, figure1.com, FIGURE, Roman numeral, or the number 1.com, for cases like this and others that allow interaction on live de-identified cases 24/7, 365. And with that, I will ask for your appreciation and thank you also for your attendance at this excellent presentation. And thank you so much, Dr. Babu. Hope to see you and meet you in the future, and appreciate your contributing to our archives, Global Grand Rounds. And with that, we will close the meeting. Bless you all, and thank you again for your attendance.
Thank you, Dr. Babu. Thank you, Pecchia. That was a great one. I appreciate you.
Very good. Thank you.
Bye-bye.
Bye.
Bye-bye.